So I'm Finn Gustafsson. I'm a professor of cardiology with interest in heart failure, working at the University Hospital of Copenhagen, Rigshospitalet. The Reduced Lab Heart Failure 2 trial was a trial randomizing patients to an atrial shunt or a sham procedure, and these were patients with HFpEF or mid-range EF with symptomatic heart failure. And the trial, the 12-month data of the trial, which presented last year, showed that there was a neutral result in the overall population with the intervention compared to sham. Now we're looking at the 2 years outcome, so the longest study ever of a shunt device and the treatment of HFpEF or mid-range EF. And what we found in this study was that the neutral effect was similarly seen now after 2 years. We also saw that the safety signals were similar, so very low range of adverse events. Then, of course, the interesting part is, what about the patients that we saw at 1 year who really responded well to therapy? Did they also respond well still after 2 years? And this was the primary intention of this analysis that we presented here. And what we found was that, yes, indeed, this group of patients without a pacemaker who does not have what we call latent pulmonary vascular disease responded very well to the therapy. I think the 2-year data is really important for several reasons. First of all, it provides long-term data on safety. And this is really important if we want to treat a responder population. So that's one really important thing. Also, I think the robustness of the signal really showing that even after 2 years, we see the identical response in the responder population certainly makes me think that this is a population that we can look for, we can identify, and that we can randomize in a new trial to understand whether they truly have this effect also in a randomized setting. But from that perspective, the 2-year data is really important. Well, I think that if we look at the responder population, so the ones without pacemaker, without exercise-induced vascular disease, there was a reduction with a 50% reduction in the incidence of heart failure events over 2 years. That is a very large and very important reduction in heart failure events that we have not seen with, for instance, drug therapy in HFpEF and mid-range EF. So this is really a critical finding. I think it tells us that shunting can be a real therapy for the correctly selected patient group. So this teaches me about the pathophysiology of HFpEF and mid-range EF patients. So from that, it also adds to my pathophysiological understanding of the disease. Of course, in the end, we need to prove in a prospective randomized trial that putting in a shunt in these patients is superior to a sham procedure or no treatment in the relevant, correctly identified population. So the Responder HF trial is a trial now that is aiming at this particular population without exercise-induced pulmonary vascular disease and without a pre-existing pacemaker, and looking at whether implantation of a Corvia atrial shunt will improve outcomes. And this is still crucial for the treatment of these patients. We have drugs that work in these patients, but if we really go into the details, the effects on outcomes of many of these patients is actually quite modest. So there is a huge treatment gap still for this population. And in particular, these patients that we really can identify as hemodynamically aberrant HFpEF patients that have this disease is certainly a group that needs help, and that's where this device potentially, if the Responder heart failure trial comes out positively, will have an excellent option for that.